Cardiovascular disease is quietly establishing deep roots in young, seemingly healthy populations long before any outward symptoms appear. Clinical data now places the reported prevalence of pediatric hypertension between 2 and 6% globally. Elevated blood pressure in adolescence tracks directly into adulthood. A child with persistent hypertension is actively building the foundation for premature heart attacks, strokes, and renal failure. The clinical risk multiplies based on two major factors. Children with a blood pressure reading above the 90th percentile carry a 2.4-fold greater risk of sustained hypertension. For obese children, that risk triples, with prevalence rates climbing as high as 30%. Effectively managing pediatric hypertension requires discarding fixed adult metrics entirely. Instead, clinicians must rely on dynamic, percentile-based diagnostics, master precise mechanical measurement techniques, and hunt for secondary etiologies. An elevated blood pressure reading in a child is rarely the primary disease. It is almost always a mechanical distress signal originating from another failing organ system. Inside the clinic, diagnostic logic relies entirely on the physical precision of the initial measurement. Looking at these blood pressure cuffs, we see a strict progression of equipment. Securing an accurate reading in pediatrics requires selecting the exact tool from a range of specific sizes. The first strict physical requirement is longitudinal. The inflatable bladder inside the cuff must cover at least 2/3 of the child's upper arm length. The second is circumference. The cuff must completely encircle 100% of the arm to ensure uniform compression of the tissue and underlying artery. Using a cuff that is too short or too narrow concentrates the physical force, which artificially inflates the blood pressure reading and creates false positive diagnoses. Once properly compressed, the clinician auscultates for the Korotkov sounds. The very first knocking sound dictates the systolic reading. When that knocking sound completely disappears, the fifth Korotkov sound, that marks the diastolic pressure. Without adhering to these rigid physical cuff dimensions, the reading is artificially skewed. Any subsequent diagnostic data is corrupted and clinically useless. A static metric like 120/80 fails completely when applied to growing bodies. This 3D graph illustrates the dynamic pediatric normogram. It calculates cardiovascular risk based on three constantly shifting variables: a patient's age, their sex, and their height. A strictly normal reading only exists in the zone falling below the 90th percentile for a child's specific demographic metrics. Pre-hypertension occupies the space between the 90th and 95th percentiles. A systolic reading between 120 and 129 also triggers this classification, regardless of the percentile. The true clinical disease states begin above that line. Stage 1 hypertension is any sustained pressure above the 95th percentile. Stage 2 hypertension breaches the 99th percentile. To rule out anatomical defects, clinicians must obtain blood pressure readings in all 4 limbs. Significant variations between the arms and legs expose hidden vascular lesions, such as coarctation of the aorta. Pediatric hypertension is a moving target. Diagnostic precision requires continuous recalculation against the child's unique biological growth curve. Knowing how to measure the pressure thresholds allows us to identify what is actively driving these elevations from within the body. This formula dictates systemic blood pressure. Blood pressure equals cardiac output multiplied by peripheral vascular resistance. Primary or essential hypertension often presents in adolescents with a genetic predisposition or obesity. But secondary hypertension involves another pathology actively manipulating these variables. In infants and younger children, severe hypertension is overwhelmingly secondary. Specific disorders hijack different parts of the equation. Endocrine tumors secrete excess catecholamines, which rapidly spikes heart rate and drives up cardiac output. Conversely, central nervous system disorders alter sympathetic tone, heavily increasing peripheral vascular resistance. To resolve the pediatric case, the clinician must treat the equation by identifying which underlying organ system is forcing the hemodynamics out of balance. The vast majority of secondary pediatric hypertension traces back to renal pathology, including Wilms tumor, renal artery stenosis, or chronic pyelonephritis. The cascade begins when structural damage or blockages reduce glomerular perfusion. The juxtaglomerular apparatus senses this drop in blood flow and sounds the biological alarm. This flowchart tracks the ensuing chemical cascade. It starts with the kidneys secreting the proteolytic enzyme renin into the bloodstream. Renin seeks out its primary substrate, angiotensinogen, and converts it into the inactive compound angiotensin 1. That inactive compound travels to the lungs, where the angiotensin-converting enzyme transforms it into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. It dramatically narrows the systemic arteries, triggering a violent spike in peripheral vascular resistance. Simultaneously, angiotensin 2 targets the adrenal glands, stimulating them to release the hormone aldosterone. Aldosterone forces the nephrons in the kidney to reabsorb sodium. Because water strictly follows sodium, the body retains massive amounts of fluid, pushing total blood volume up and heavily spiking cardiac output. This dual mechanism, shrinking the arterial pipes while forcing higher fluid volumes through them, causes chronic, dangerous structural remodeling and hypertrophy of the heart over time. While long-term pathology remodels the heart slowly, Stage 2 hypertensive crises demand immediate emergency intervention. The absolute therapeutic goal is to pull the blood pressure safely back down below the 95th percentile limit. This graph illustrates the severe danger of treating a crisis incorrectly. Attempting to drop blood pressure to normal levels instantly can be fatal. Intervention requires stepwise reduction. In the initial phase, clinicians use intravenous agents to achieve only a 1/3 reduction in pressure over the first 6 hours. In the second phase, the remaining 2/3 reduction is managed gently over the next 48 to 72 hours. If pressure drops too fast, the brain and optic nerves, adapted to the high-pressure environment, suddenly lose their oxygen supply, resulting in dangerous ischemic damage. During a crisis, reducing the pressure too quickly is as dangerous as the hypertension itself. Long-term pharmacological treatment is a matter of targeting the exact compromised variable in the hemodynamic equation. ACE inhibitors like captopril are deployed to sever the renal chemical cascade, stopping the production of angiotensin 2 and eliminating the chemical signal causing vasoconstriction. For volume-dependent hypertension, diuretics like furosemide flush out retained sodium and water, actively lowering cardiac output. Calcium channel blockers directly target vascular resistance, relaxing the muscular walls of the arteries so blood can flow with less friction. Childhood hypertension is the mechanical symptom of an internal threat. Mastering rigid physical measurement, understanding percentile thresholds, and decoding the underlying renal and vascular cascades is the reliable way to protect a child's cardiovascular future.